Welcome to this video on perinatal asphyxia and hypoxic-ischemic encephalopathy, or HIE. Perinatal asphyxia is a condition caused by a lack of oxygen and/or perfusion to fetal or newborn organs. This results in anaerobic metabolism, lactic acidosis, and potential multi-organ system failure. It can occur before, during, or after birth, with 70% of cases happening intrapartum. Diagnosis of birth asphyxia typically requires metabolic or mixed acidemia, an APGAR score of 0 to 3 for more than 5 minutes, neurological manifestations like seizures, and evidence of multi-organ system dysfunction. Brain injury progresses through 3 phases: the primary phase of initial energy failure, the latent phase of apparent recovery, and the secondary phase involving delayed cell death. The primary goal of care is to minimize damage during the latent and secondary phases. Hypoxic-Ischemic Encephalopathy, or HIE, is the clinical neurological syndrome following perinatal asphyxia. Staging using the SARNAT and SARNAT system is vital for predicting prognosis and guiding treatment. SARNAT Stage 1, or mild HIE, involves hyperalertness, normal tone, and no seizures. The prognosis is usually excellent, with most infants recovering completely within 48 hours. SARNAT Stage 2, or moderate HIE, is characterized by lethargy, hypotonia, and common seizures requiring management. The prognosis is variable, necessitating intensive monitoring and support. SARNAT Stage 3, or severe HIE, presents with stupor or coma, flaccid tone, and frequent seizures. This stage carries a high risk of mortality or severe neurodevelopmental disability, such as cerebral palsy. Asphyxia is a systemic disease. We must monitor for multi-organ involvement, including renal issues like acute tubular necrosis, cardiac problems like myocardial ischemia, hepatic dysfunction, and metabolic imbalances such as hypoglycemia and hypocalcemia. Management includes maintaining normal CO2 levels and avoiding hypocapnia to prevent worsening brain injury. We must ensure adequate perfusion by maintaining mean arterial pressure and restrict fluids slightly to prevent cerebral edema. The first-line treatment for neonatal seizures is phenobarbital. Second-line options include phenytoin or levetiracetam. Nursing staff should carefully differentiate seizures from jitteriness, which stops when the limb is held. Therapeutic hypothermia, or cooling the body to 3.5 degrees Celsius for 72 hours, reduces the metabolic rate and prevents the secondary phase of cell death. It is indicated for term or near-term infants with moderate to severe HIE. Nursing monitoring for HIE is critical. Key areas include neurological assessment, strict input/output monitoring for renal failure, maintaining stable blood glucose, and proper positioning to reduce intracranial pressure. Evaluating primitive neonatal reflexes, such as the Moro, suck/swallow, and grasp reflexes, helps track neurological recovery and determine the infant's ability to safely feed. Parental support and counseling are essential due to the emotional strain of asphyxia cases. Clear, empathetic communication is key. Early intervention and rehabilitation can improve the quality of life for severe cases. In summary, prevention through high-quality intrapartum care is the best treatment. The first 6 hours are the window of opportunity for neuroprotection. Our key takeaway is to aggressively protect the brain by monitoring glucose, blood pressure, and seizures. Thank you for watching this video.